Hi, my name is Ann Sales, and I'm a faculty member in the Department of Learning Health Sciences at the University of Michigan Medical School. This video presentation is a very brief overview, in a nutshell, of process of implementation for a particular intervention, clinical intervention that has relevance to COVID-19. It's just one example. The process I'm going to be describing could be used for many other kinds of examples as well. So I'm going to start just by a brief definition of implementation. I define it, and this follows definitions in dictionaries and textbooks, as a process of planned human behavior change under organizational constraints. I'm not going to spend a lot of time describing the elements of this, except to say the real focus here is this is about planning systematic change in the way we as humans do work, usually. Sometimes it's about change in our own lifestyles and behaviors. But in this case, for implementation, this is more about the work we do. And it's within the context of organizations. These can be big formal organizations, or they can be community organizations, or even informal networks within communities that are still organizations and structures of their own kind. The reason it's important to think about what the definition of implementation is that it leads to the definition of the science of implementation, the study of planned human behavior change under organizational constraints. I'll be talking more about these elements as I talk through the example that I'm going to be showing in these slides. And then finally, I just want to say there is also implementation practice, which can also be thought of as quality improvement, where using the tools that have been developed through implementation science and implementation research, we engage in the process of supporting human behavior change under organizational constraints, planning and supporting human behavior change. So this little graphic is one I'm going to talk through during the next few slides. This is a quick presentation. It's not intended to be in-depth, but just an overview of what we mean when we say doing implementation. Thinking again about the definition that I just presented. We start off with a problem or a gap of some kind and think about evidence-based solutions to those gaps or problems. This is an area with some degree of argument and uncertainty, because the amount of evidence we have for covering all of the problems and gaps that we can identify is highly variable. Some problems don't have great evidence-based solutions. And so then the question is, what makes sense in terms of changing behavior and improving the processes of care that are being delivered and people being served today? We use process models. This is one small example of one. We have many different process models within implementation research and implementation to plan how to enact the behavior change that we're talking about. And one of the key pieces of the process models that we use in implementation that come from implementation research uses what are called determinant frameworks to understand how to design implementation interventions, the ways we're going to use to overcome barriers and facilitators, also known as determinants of implementation, the kinds of things that make it difficult to change behavior. This graphic here is from a paper published in 2013. It's one of a group of consolidated frameworks, determinants frameworks within implementation research. And it's called the Tailored Implementation for Chronic Diseases Checklist. Part of the reason I focus on it and use it, even though there are many other determinants frameworks that are out there in the literature, two of which are well known and have been used longer than TICD has been around, include the Consolidated Framework for Implementation Research, or CFIR, and the Theoretical Domains Framework, or TDF. Both of those actually were included and consolidated along with 10 other frameworks that already existed when the TICD was published in 2013. The important use of these determinant frameworks is to understand the barriers and facilitators that need to be overcome or enabled to make implementation of a new evidence-based process happen, to enable the behavior change that needs to occur for the desired outcomes to be put into place. And we do that using strategies. There are a few different taxonomies of strategies that have been developed and tested through implementation research. This is from a paper that was led by Tom Waltz, published in 2015, and it shows a particular configuration or cluster of strategies as determined by a group of stakeholders and researchers. We apply those strategies to enable behavior change to happen, and then we evaluate whether what we did worked or not. Was it effective? Did it reach the kinds of people and the people that we wanted it to reach? Is it something that can be maintained? Was it adopted in the first place? Those are questions that the REAIM framework, which has been an evaluation framework in the implementation research literature for many years, addresses and gives people information about how to answer. And then I want to just stress that throughout this whole process, all of these steps that I've just gone through, we also focus on how we work with stakeholders, and identifying stakeholders, assessing, analyzing, and engaging with stakeholders is a critical component of doing implementation, as it is doing quality improvement work. So the example I'm going to talk about today has to do with patients who are mechanically ventilated. So this is a group of very, very ill patients in some form of respiratory failure, usually, and who require assistance getting from being ventilated to being able to be up and ambulatory in, excuse me, as they progress from the health condition that caused their need for mechanical ventilation to recovery and ultimately discharge from the hospital. These are patients who are usually cared for in critical care or intensive care setting, and their care is very high-end technologically, and requires a lot of human labor to ensure that the care they're receiving is adequate. So starting with the first steps from that little process diagram that I showed you, we start with defining the problem. In this case, I'm centering this around the COVID-19 pandemic because it induced a lot of respiratory failure in a much larger group of patients than we usually see routinely in inpatient care. And it really highlighted the need for use of evidence-based practices for patients who are mechanically ventilated. In particular, the specific example I'm going to focus on today is called lung protective ventilation. Because you're using a machine to breathe for the individual, the machine's settings actually dictate how much the lungs expand. When they expand too much, they can be injured. So it's really important to ensure that when you set ventilator settings, that they are set so that lung injury will not occur. And the problem here is that many times those settings are not carefully enough assessed. We may not know what the patient's ideal body weight is, which is essential to know in order to calculate the lung protective ventilation volume that's appropriate, or the volume just doesn't get set appropriately in the first place for reasons that aren't always easy to identify. So the problem is patients are started on mechanical ventilation that is not lung protective, and therefore there's a potential for injury. Using process models, and again, this is just one example of a process model, we start the process of planning, working through decisions about how to move forward with the process of implementation, and making decisions, importantly, about what evidence to implement. So there are clear guidelines from systematic reviews, meta-analyses, and many underlying empirical randomized trials that demonstrate that lung protective ventilation does help to preserve lung function. There's one piece of this that's a little bit complicated in that it is clear for one group of patients, those who progress all the way to acute respiratory distress syndrome, which is very advanced, severe form of respiratory failure. But it's not so clear for all patients who experience acute respiratory failure and therefore may be ventilated. So one thing that to think about as a determinant is, do we know whether this patient has acute respiratory distress syndrome, or are they perhaps not quite that severe? So then we move into the process of assessing determinants, the barriers that facilitate to implementing lung protective ventilation. The kinds of things that we find when we do empirical research and interviews or surveys with providers are that in an intensive care unit, patients actually arrive in the intensive care unit already mechanically ventilated and already on high ventilator settings. And it's not always the case that these are assessed carefully enough to make the changes that are needed to reduce the lung volume that's being pushed into the lungs, and that patients are actually receiving lung protective ventilation. Sometimes another barrier can be that the staff may not have enough knowledge of the evidence about lung protective ventilation, even though the evidence has been in the literature for around 20 years. It hasn't been communicated effectively to all the staff who need to understand it and use it as they care for patients. So this is all part of the process of assessing determinants and ensuring that we use them effectively. It's important to use a specific framework that focuses on determinants. We have over 100, more than 100 frameworks in the implementation research literature. They're all of different types. Determinants frameworks are specifically about the barriers and facilitators, the determinants of implementation success, a critical set of issues that we want to think about as we plan for the process of behavior change. The other piece to think about here is under organizational constraints. I just want to note that there are many different domains within the TICD, the Tailored Implementation for Chronic Diseases Checklist. And several of those are at a level beyond the individual healthcare provider, the individual patient. They're about the teams and networks, the interactions among professionals, the incentives and resources that are used, and the capacity for organizational change. Clearly focusing on the organizational level and understanding how that organizational level either enables or constrains individuals from changing their behavior and taking the action that they may well know and understand they need to take. And then finally, a set of factors that can operate beyond the organization in terms of policies, payment systems, what's available in the setting. When we think about global health, there are issues around resource constraints that are at the national or regional levels beyond what an individual organization can and cannot do. So finally, in the last two steps, and I'm moving through this very quickly, we need to think about how we link from assessing determinants, understanding the things that affect the success of implementation, to the strategies we're going to design and develop and use to overcome those barriers and actually implement the thing that we are trying to implement. And designing implementation interventions is a whole focus area for implementation research, but it's also an important component of implementation practice. There are frameworks that catalog strategies. One of the best known in the United States is called the ERIC framework. And this diagram comes from the ERIC project, which was all about understanding implementation and change techniques to change behavior. It's still not entirely clear how we go from assessing determinants to figuring out what strategies will actually deal with those determinants. But that's the kind of area that research is active in. And I would encourage you, as you think about research in this area, to think about this being an area to focus on. Within the lung protective ventilation area that we've been talking about, the example that we've been using, some of the things that are strategies are giving people a checklist for the assessment as a patient is transferred into or admitted into an intensive care or critical care unit. And one of those pieces on the checklist would be to check the ventilator settings, ensure that they are appropriate for this specific patient, that this is not a small person who is getting tidal volumes from the ventilator that are going to expand their lungs to the level that would only be appropriate if this was a very big person. And then perhaps training, crash courses in how to manage ventilator settings if, for example, staff are not familiar with these. We then need to think about how to evaluate what we're doing. And there's a set of outcomes that are specific to implementation that are becoming quite prominent in the literature on implementation, things about acceptability of the implementation strategies and of the intervention to be implemented, feasibility, cost issues. But we also want to think just about, does this thing work? And because we're using evidence-based practices, we should have a basic knowledge about how this should work in the settings in which it has been tested. But we always need to retest that within the settings in which we're doing the work, because they may differ from the settings or the populations that were used initially with patients in perhaps high resource settings versus low resource settings. Finally, we have to think about iterating through the steps again, because this is seldom a process that happens and works perfectly the first time through. We often find that there are things that didn't go so well, and we need to think about how to reinforce those, amplify them, and check again. In this, it's very similar to the plan, do, check, act cycle that is commonly used in quality improvement. Very briefly, I want to focus a little bit on who are the stakeholders, and to mention that there are frameworks even here that are relevant. This particular framework uses P as the first letter as a way of remembering the whole group of potential people involved. The little graphic I use puts the patient at the center, which I think is an important thing for us to consider, especially when we're talking about clinical interventions. But it's also true for information technology interventions. If the patient is out of the picture, then we're not necessarily thinking of them as a stakeholder. And that would include their families, friends, and caregivers, as well as the patients directly. Physicians are usually involved, particularly in any formal healthcare setting. Nurses are involved in many healthcare settings, and in some settings like hospitals, they're the largest group of providers. Important to consider the role of social workers and other people who are often the links between a hospitalized patient and the community, or ensuring that community resources are used appropriately. It's important to think about the pre-hospital system of care in terms of emergency services. So thinking about paramedics and also pharmacists who span settings. Pharmacists are providers within hospitals, but they are also out in communities in retail settings, and can often be the person that a lot of patients interact with the most during their regular normal course of their lives. In this particular example, just to go through it quickly, the patients are often not able to advocate for themselves because often they're sedated. If they are in acute respiratory failure and unable to breathe, their bodies will be shutting down and they won't be conscious and able to tell people what they want and how they want to be treated. So we rely on family members, often other community members, to advocate for patients as well as to help plan their care. Among providers, excuse me, physicians, and in teaching hospitals, trainees, residents, fellows are all important people. Nurses, respiratory therapists, other care providers who include pharmacists, social workers, and so on. And then I think we have to think about the level of leadership and how resources are provided to the unit. This gets into the question about what is the organization? How does it enable the care that's provided? How does it sometimes constrain how behavior is managed and how it's changed? This comes from a paper by Enola Proctor and her colleagues that was published in 2013, and it lists a group of things you have to think about as you specify strategies that you're going to use for an implementation project. I'm not going to go through these in great detail, but the key point I want to make is you need to identify stakeholders in order to know who the actors are. You should also think of yourself as an actor if your job is to do implementation or to do quality improvement. You should think about the actions that you're trying to influence. What is the behavior that currently is being used? What are the processes that people are engaging in? And how do those need to change? Who needs to change their behavior? How do they need to change it? When do they need to change it? And all of these are part of specifying and being able to, again, plan ahead and think about the whole process as opposed to just sort of experiencing it as issues come up and dealing with them in a much less systematic way. I hope this has been helpful, and I'm sure that you'll be learning a whole lot more about other processes and going into depth on many of the ones that I've covered today. Thanks.